Kim. I'm a medical anthropologist based at the Developmental Pathways for Health Research Unit at WITS, and I'm also a postdoctoral research fellow at the Massachusetts General Hospital in the United States. Thank you very much for attending my talk, and thank you to the organizers for allowing me to present my research to you today. And today I'll be presenting to you some data that from a study that we've been conducting on the mental health impacts of the COVID-19 pandemic among psychiatric healthcare workers in Johannesburg. And the title of my presentation is PsyCOVID: Perceptions, Experiences, and Impacts of COVID-19 among Tertiary and Specialized Psychiatric Hospitals in Johannesburg. So as many of us know, the COVID-19 pandemic first started in South Africa in the beginning of March 2020, which is when the first confirmed case of COVID-19 was detected. And a few weeks later, President Cyril Ramaphosa commenced a South African lockdown. And now there are a number of different reasons as to why the COVID-19 pandemic was going to pose high levels of concern in the country. And this was multifold. This included high rates of pre-existing comorbidities, such as NCDs and infectious diseases like HIV, and also elevated rates of different forms of social marginalization, including poverty and unemployment. There are also a number of reasons as to why the mental health concerns in COVID-19, during COVID-19, were notable. And this included many people's inability to adhere to social distancing, quarantine, other forms of risk mitigation against COVID-19, as well as the adverse social conditions during lockdown that we've seen, including food insecurity and poverty, harsh enforcement of government sanctions that we've seen, especially in marginalized communities, and also concerns for mental health care users, including potential risks for drug defaulting, lower adherence to medication and treatment, and elevated risks for relapse. We've also seen mental health concerns for individuals that have been infected with COVID-19, such as a wide array of neuropsychiatric sequelae, which is still something that the literature is still examining. But overall, we see that a number of mental health concerns are posed as a result of the pandemic, both among individuals who are affected by the pandemic through secondary aspects, as well as individuals who are affected by COVID-19 directly. Now, many of us know that the mental health, the picture of mental health in South Africa was already quite bleak before the COVID-19 pandemic started. This included elevated rates of psychiatric disorders among in South Africa. Some data suggesting that the rates of psychiatric disorders are among the highest across the sub-Saharan continent. About a quarter of severe cases are treated in the country, and we see that there's generally very low access to mental health services in the public psychiatric sector. Recent analysis has shown that the treatment gap is 92% for individuals who have mental illnesses, meaning that only 8% of individuals who are in need of mental health treatment actually receive it. And this picture as a whole shows that the mental health system is both overburdened and under-resourced. So given the systematic resource constraints and the high mental health needs, as well as the new forms of both social, economic, and psychiatric adversity that are introduced by the COVID-19 pandemic, we wanted to investigate, what were the impacts of the COVID-19 pandemic among the psychiatric healthcare sector, specifically trying to identify the impacts among individuals who cared for individuals with mental health conditions. So we had the major study question was, what are the mental health impacts of working during the COVID-19 pandemic among psychiatric healthcare workers? And there are two parts of our study. The first, which is a quantitative side of our study, examined psychiatric morbidity and specifically aimed to identify the occupational stressors that healthcare workers face during COVID-19, as well as calculating levels of psychiatric morbidity during our the study timeframe. And the second study aimed to examine qualitatively occupational stressors and social experiences among psychiatric healthcare workers during the pandemic. For this part of the presentation, I'll be presenting you the quantitative findings. So both studies were conducted across 5 specialized and tertiary hospitals across Johannesburg and southern Gauteng. This included Sterkfontein, Tara, Helen Joseph, Baragwanath, and Charlemagnoge. There were 4 methodologies that we used to assess the mental health impacts and experiences during the pandemic. This included in-depth qualitative interviews, psychiatric and COVID psychiatric interview screeners that assess different symptomatologies for depression, anxiety, PTSD, and others, as well as a variety of different surveys that assessed social experiences, such as healthcare-related stressors during COVID-19. We've been conducting a record review, which is still ongoing, which I won't be presenting in this presentation. And all of these data are also supported by over a year of clinical ethnography that was conducted in a psychiatric ward in Johannesburg. To note, the study began at the beginning of the second wave, so many of these data are retrospective, and we've continued to conduct data collection from the beginning of the second wave onwards. Today, the focus of the data will be, or the time frame in which the data was conducted was between the beginning of the second wave, or near the beginning of December, to the end of March of 2021. So our COVID-19 survey, which assessed both social experiences and psychiatric morbidity, was conducted online. And we conducted collected data on a variety of different measures, including social demographics, a variety of experiences related to COVID-19. This included a collection of stressors and traumatic events that were experienced within hospital settings, which we call the healthcare-related stress survey. And we also collected data on a variety of other COVID-19 related experiences, such as coping, general stress, as well as moral injury. And we finally conducted a variety of different psychological screeners to assess psychiatric morbidity. And again, this was to assess depression, anxiety, PTSD, risk for mood disorders, and other social experiences. So jump into our study findings. The first body of results that I wanted to present to you was to characterize the different social experiences and stressors that individuals faced working inside psychiatric facilities. These are the top 10 sources of stress that healthcare workers noted. And these include infecting family, infecting friends and others, feelings of burnout, and the potential for infecting patients with COVID-19. As you can see, the top 5 stressors were all related to COVID-19 infection, as well as burnout. And the second set of stressors were related to different work-related pressures, such as high levels of work demands, and fears of letting one's team members down, and different forms of stressors that were related to poor communication and not having enough personal protective equipment, which I'll delve into later. This was just a small collection of a much wider variety of stressors that we experienced, but I just wanted to highlight the most salient and stressful measures that healthcare workers noted. Here I present the levels of psychiatric morbidity among healthcare workers in our sample. And as you can see here, there were elevated levels of depression, anxiety, and post-traumatic stress symptoms across healthcare workers, where we see nearly a quarter of individuals expressing symptomatologies for depression. This is based on the PHQ-9. About a fifth of individuals noting symptoms of anxiety, and 13% of individuals noting symptoms for post-traumatic stress disorder. So for this set of analyses, we conducted a variety of multiple regression models to identify the relationship between healthcare-related stressors during COVID-19 in psychiatric facilities and its association with different psychiatric symptoms. So here we first see that a strong correlation between greater levels of COVID-related stress during levels 3 to 1 of the lockdown and greater levels of depression. We also see similar relationships with anxiety, where we see a direct relationship between COVID-19 related healthcare stress, so greater levels of stress corresponding with greater levels of anxiety symptoms among our participants. And finally, a similar trend between healthcare related stress due to COVID, as well as PTSD symptoms in our sample. So as a whole, our first study showed that showed greater levels of, or elevated levels of psychiatric morbidity and a variety of different stressors that were faced during the COVID-19 pandemic, specifically related to healthcare-related stressors. Now, the second study that we conducted examined the qualitative experiences to delve more into these statistical models. What were people actually facing? What were their thoughts and beliefs and their feelings, as well as their perspectives on COVID-19, as well as what was going on in the hospital settings. So here I present 4 salient themes across in-depth interviews with approximately 55 individuals. The first set of themes that was really salient, probably actually the most salient in our analysis, was the fear and risk of COVID-19 infection. Now, we found that nearly all of our study participants expressed an extreme and deep-seated fear of becoming infected with COVID-19. These concerns were driven by unsafe working conditions, the fear of infecting patients and family members, and the fear of death. Healthcare workers had to juggle numerous factors for COVID-19 infection, many of which were unavoidable. And some staff also noted that their patients' compromised psychological state, specifically their limited ability to comprehend the severity of the virus and adhere to safety protocols, also raised their fears of passing on COVID-19 to their patients. Now here we have a representative quote from one of our participants, which really summarizes this theme very well. Quote, "It was scary and it felt as if the situation of trying to contain the outbreaks in the different parts of the hospital could go out of control very quickly. With regard to patients, there were too many patients to quarantine and too many PUI patients or patients under investigation to try and isolate safely. The numbers were such that our neat plans of having specific areas and specific numbers of beds for quarantine, isolation, etc. were totally inadequate in terms of numbers. There are not enough beds in the specially designed areas for these purposes. It became more of a matter of trying to do one's best." The second theme was around PPE shortages. And PPE shortage was among the greatest sources of stress for hospital staff. At the onset of the pandemic, psychiatric hospitals lacked many of the essential items necessary for an appropriate COVID-19 response, as these items were not required for psychiatric care. This included personal protective equipment, oxygen concentrators, and ventilators. These tensions heightened when healthcare workers were placed at high-risk occupational environments. Some nurses noted that they saw higher-level managers and administrators who had little interaction with COVID-19 patients donning better equipment, such as N95 masks. And as a result, healthcare workers directed their disdain for their occupational conditions towards managers and government officials. One of our participants noted, quote, "I'm so angry with them. I'm still angry with them. Other institutions don't have PPE, and then they do come in contact with people with COVID. It's not really safe for us." The third area was around staff shortages and redeployment. Before the pandemic, as many of us knew and have experienced, hospitals already faced major resource constraints, such as staff shortages, long patient waiting lists, medication stockouts, and others. Some participants who were forced to quarantine after becoming symptomatic or contracting COVID-19 expressed deep guilt and moral injury for placing extra work on their colleagues. Healthcare workers frequently allocated to different wards and expected to provide services that they were not adequately trained to deliver. And as a result, the redeployment of staff to new units and mandatory testing procedures led to very negative reactions among staff, including anger, passive-aggressive attitudes, complaints, and absenteeism. Staff shortages also had negative impacts on psychiatric education, as some students and registrars noted that they had to treat COVID-19 patients rather than getting the adequate psychiatric education that they had signed up for during that particular round. So this is an exchange between the interviewer, myself, as well as one of the participants. So I asked, did you ever feel that there was a time when you were burnt out? The participant answered, yes, it was too much. I think during the level 5, I think most of the time I was just dragging myself to come to work. It was just too much. I just felt very demotivated, demoralized because of the numbers that were going high, especially of the staff members. I'm still really, required to make sure that patients were well looked after, even though the nurses have gone on either isolation or they've gone on quarantine. So it was very, very, very tough. I think, yes, I have felt burnt out before. And finally, the last area that came up in our qualitative research was around chronic infrastructural constraints. All hospitals noted limited space to manage COVID-19 patients and PUIs, which also posed massive health issues for healthcare employees. And this was symbolic of broader infrastructural problems in the public psychiatric healthcare system. In some instances, PUIs awaited their results before entering the ward and with other non-symptomatic patients, thus leaving everyone in the ward at risk if the patients did have the virus. To remedy this, clinical teams closed a handful of wards to create spaces for quarantining, monitoring, and treating COVID-19 positive patients and PUIs, which resulted in some hospitals temporarily discontinuing vital psychiatric services. One participant noted, quote, "We were not prepared. We had no ward spaces which were immediately available for use for COVID-19 related use. We were already struggling to adequately accommodate our usual patient population and to admit new referrals. In my mind, as things were at that time, we were not in a position to be able to handle a situation such as a pandemic or a major public health emergency." So together, we've come up together with a set of recommendations for healthcare practitioners as well as the Department of Health to improve the mental health situation within psychiatric healthcare facilities within the larger context of COVID-19 and for public health across the country. And so there are 3 recommendations. The first is to implement initiatives to improve staff psychological well-being and mitigate burnout. The immediate psychological needs of staff should be identified. Regular counseling and listening sessions in conjunction with psychology departments should be organized, and referral pathways for the deeply afflicted should be established. Stigma poses a massive barrier to utilizing psychological resources, even among psychiatric healthcare workers, and hospital leaders must normalize and model regular mental health hygiene. The second recommendation was to maximize hospital preparedness for future healthcare emergencies. A disaster preparedness protocol should be developed and or updated to use during future health emergencies or pandemics. Areas of need should be identified in the plan, and individuals to ensure that all resources and competencies are obtained should be mobilized and trained. And finally, we must combat challenges to service delivery in the public mental health care system. Now, numerous resources for resource and infrastructural development are necessary to combat the many challenges to service delivery during the COVID-19 pandemic and future pandemics and emergencies. These include increased funding to eliminate medication stockouts, long waiting lists, staff shortages, and limited physical infrastructure for more workspace and beds. National and provincial governments must guarantee the implementation of and adherence to the most recent national mental health policy framework and strategic plan. So in conclusion, we see that there are elevated levels of depression, anxiety, and PTSD symptoms among psychiatric healthcare workers during the second wave, around the second wave of the COVID-19 pandemic. Greater COVID-19 healthcare stress was directly associated with increased depressive anxiety and PTSD symptomatology. We see that there's great levels of fear of COVID-19 infection, PPE and staff shortages, and chronic infrastructural constraints that occurred, especially during the first waves of the pandemic. And all of these we identified were potential mental health risks. And in some, greater emergency mental health resources and sustainable improvements in public mental health care systems are needed. Thank you very much for your time and attention. And I'm happy to take questions over email, which I hope will be sent to the conference participants at the end of the presentation. Thank you very much.